Giving this talk about VEXAS syndrome that has really been the hot topic in hematology for the past couple of years, but also involves many other subspecialties. And that's why the title that I chose, the urgent need for a multidisciplinary approach, especially to diagnose and find these patients and then eventually to treat. So to understand these, the objectives are to review the approach that led to the discovery and description of VEXAS syndrome in late 2020, learn how to recognize these patients, and then understand the few but available treatment options that we have. And to fulfill these objectives, I'll take you to through a small background, how the discovery of UBA1 gene mutation happened at the NIH, the pathophysiology that this cause, the clinical manifestations of VEXAS, the mortality, which is important, and again, the few treatment options that we have available for these patients, and ending with a conclusion. So to start, not specifically for VEXAS, but a general background that I think that is important for people to understand. We need to know that somatic mutations occur after the first zygotic division. So these are acquired mutations that then we do not pass into our offsprings. And the frequency increases with age. So we see frequent mutations in elderly population. And then clonal hematopoiesis, which is a specific type of somatic mutations that happens in blood cells, and it happens in genes that are associated with myeloid malignancies, have been associated with inflammation and cardiovascular disease. So these are patients that we call CHIP, so hematopoiesis of indeterminate potential, because they do not have cytopenias, they do not have a specific disease, but they have these mutations, and with time we have understood the relationship between these changes in the genes and many inflammatory diseases and cardiovascular disease. And also before we knew how somatic mutations in some hematologic diseases are related with inflammatory manifestations, or even some well-known or described rheumatologic conditions. Some examples include NLRP3 associated inflammatory disease, Felty syndrome that's driven by STAT3 mutation, or Erdheim-Chester disease that is driven by BRAF. So the concept of VEXAS is really not new. We know about this interplay between hematologic and inflammatory conditions driven by somatic mutations, but this is definitely a new mutation, and how it was discovered and then what triggered has been very excited. And I'm also very happy to have been part of this. So this is the seminal publication that came out in New England Journal of Medicine at the end of 2020, where the group at the NIH, I wasn't part of them yet, but they basically, what they did is that they have a very big database of genetic information. They looked at patients that have different type of symptoms, manifestations without a clear diagnosis, and they were looking at genetic mutations to try to see if they could identify something that was common among all these patients that didn't have a confirmed disease or a diagnosis. There's also a undiagnosed disease program that is run by the NIH. So part of the patients came from there, and then patients from other cohorts. And so they screened for exomes and genomes in 1,400 persons with inflammatory symptoms that were non-specific, and about 1,000 patients from this undiagnosed disease program. And then, so this was a total of 2,500 persons. And some of the things that they started noticing were some changes or mutations in genes that are associated with protein ubiquitination. And they ended up finding 3 men patients, 3 male, that had a specific mutation in the codon 41 of the UBA1 gene. And this leads to a change in the amino acids. And they found out that these 3 patients also shared some common clinical manifestations. So these were the first 3, and then they found 22 other patients with clinical similar presentations, and by sequencing, they confirmed that they also had the same mutations. As I said, these patients came from cohorts of relapsing polychondritis, patients just with fever, non-specific anti-inflammatory symptoms, patients with vasculitis, and 1 patient from the undiagnosed disease program. And then 7 other patients came from the University College of London. So what they found is that all these 25 patients had a mutation in the codon 41 of the UBA1 gene that produced a change in 3 amino acids. But then this gene is located in X chromosome. So we know that men only have 1 X chromosome. So the thought is that there was probably some mosaicism that could explain the variety of the clinical manifestations that these patients have. So to prove this, they took different type of hematopoietic cells, male progenitors, but also mature cells. And they found that all the progenitors, you can see here in the blue triangle, is what is representing. Lymphoid, granulocyte, monocyte, and myeloid progenitors, all of them have the mutations. But when we go to the mature cells on peripheral blood, only the myeloid-derived cells are the ones that are showing the mutation, while the lymphocyte cells do not show it, the T cell and B cell. So this is why they have described the mutation as myeloid restricted. And then to prove that this is somatic, so they look at mutations in peripheral blood where they were present, but they were absent in fibroblasts. So this was a new mutation not described before that presents in a heterozygous manner and is in general a loss of function or missense mutation. So what does the UBA1 gene does? So as I said already, it's in the short arm of the X chromosome, and it is very important to produce E1, which is a key enzyme that is part of the ubiquitin proteasome pathway, and it basically leads to the activation of this pathway, and along with other groups of enzymes, including E2 and E3. What it does is that it targets certain type of protein, and that's what ubiquitination is, to lead them to be degraded in the proteasomes. So if this pathway is not functioning, there's going to be a lot of accumulation of proteins that are supposed to be degraded, and this will lead to increased inflammation, oxidative stress, and therefore all the changes and manifestations that we're going to see in the patients. So what they found initially at the NIH is that the UBA1 gene produces 2 different types of proteins. One is UBA1A and UBA1B. A is in the nucleus and B is in the cytoplasm. And then eventually, as I said at the beginning, so peripheral T cells do not carry the mutation, while myeloid cells like monocytes, they do. So they were comparing patients, T cells and monocytes, and they found how UBA1A and B, the normal isoforms of the enzymes, were present in T cells, but in the monocytes, there was absence of the B isoform, and there was the presence of this new isoform that is UBA1C. So the conclusion is that these mutations cause this change in the cytoplasmic form of the enzyme, leading to decreased ubiquitination, increased free ubiquitin, and then this leads to abnormal proteasome degradation pathway. So this is basically what is causing the disease. And then to prove further or to understand the pathophysiology better, they use zebrafish models, and with using CRISPR technology, they produce the same mutations, and they found an increase especially when UBA1B was mutated, the cytoplasmic form. They found increased levels of many inflammatory proteins and cytokines, including interleukin-6, interleukin-gamma, interleukin-8, TNF-alpha, and beta. So as I was saying at the beginning, it's just a crossroad between an underlying hematologic mutation that causes significant inflammation, and this translates into increased levels of C-reactive protein, interleukins like 8, 10, and interferon gamma in patients with VEXAS when compared to control patients. Then, after the first 25 patients were originally described, other authors have found other mutations that also interfere with UBA1 gene, but just with a different mechanism. But they ended up leading to the same clinical manifestations. So this group in France, for example, found a missense mutation in a different codon that also leads to impaired enzymatic catalytic activity of the cytoplasmic enzyme, and another mutation in the splice acceptor site that leads to abnormal UBA1 messenger RNA. Another French group found a different type of splice motif mutation that leads to a truncated form of the UBA1 that lacks the same codon where we saw the original mutations. And then this other group found intronic deletions. So the original mutations, now that we have more patients, the original mutations are present in about 90 to 95% of patients with VEXAS syndrome. And these other rare mutations are clinically relevant, but they're only present in about 5% of the patients. So enough of all the boring stuff. And now what is important for us in clinical practice is to understand how to recognize and diagnose patients with VEXAS syndrome, right? That's the hope of the talk today. So people or healthcare providers from different specialties understand the syndrome and can make this diagnosis sooner rather than later. So now that you understand the pathophysiology, you're going to understand where the name comes from. So VEXAS comes from V. This is the only thing that I haven't mentioned, and it's because all the hematopoietic cells in the bone marrow samples have vacuoles in the cytoplasm. E comes from the E1 enzyme that is mutated, X because it's an X-linked disease, A because of all the anti-inflammatory symptoms or clinical manifestations that the patients have, and S because it's a somatic mutation. So that's where VEXAS came from. And from the original 25 patients that were described at the NIH, 100% of them were male because it's an X-linked disease. And these are elderly patients with a median age of 60s, 45 to 80 years old. And as I was saying at the beginning, we only knew about the mutation in codon 41, but then we started knowing about the other ones. And the clinical manifestations are very diverse. And that's why, again, I want to emphasize this over and over again. It is important that everyone in the audience, primary care physicians, rheumatologists, dermatologists, everyone is aware about VEXAS syndrome. Almost 100% of the patients have fever. There's a lot of skin involvement. It is thought to be the second most common manifestation, 88%. There's lung involvement, including pulmonary infiltrates, chondritis. That's why we saw that some of the patients came from cohorts of relapsing polychondritis. There's a high amount of venous thromboembolism, and this is where I've done most of my work. A lot of microcytic anemia, suggesting a bone marrow failure kind of syndrome. And what I said from the V, some vacuoles. And we have high levels of inflammatory markers, as I said at the beginning. And then we'll talk a little bit more about treatment later. But this is important that a lot of these patients had a different diagnosis before this was discovered. So some patients were thought to have relapsing polychondritis, Sweet syndrome because of the skin involvement, MDS because of the changes in bone marrow, polyarteritis nodosa, giant cell arteritis. So again, these are patients that are going to be seen by everyone, not only by hematology. And here we have some of the manifestations, so you have an idea. We have some skin changes, basically kind of like neutrophilic dermatosis, and that's why they have been diagnosed with a Sweet syndrome-like type. And we can see the infiltration in the skin of these myeloid-derived cells. For pulmonary, we have a lot of patients with infiltrates in the lungs, alveolitis, so non-specific symptoms, a lot of pleural effusion as well. There's some arteritis or vasculitis. This is from the sample of the lung with inflammatory infiltration. And then chondritis is also very important. So we see chondritis in the ears, in the nose, and we see a lot of eye manifestations that include epiascleritis or even periorbital swelling. And then finally, the hematologic changes. So these are the vacuoles that I was saying, and they're present in myeloid precursors, but also in erythrocyte or red cell precursors. And again, not present in the mature peripheral lymphocytes. So these were the first 25 patients. Around the summer of last year, we completed a review. And at that time, there were about 300 cases described worldwide. And now Beck, which is the leader in VEXAS and who led the discovery of the disease, he just published this month a very interesting study where they were trying to understand better the epidemiology and the prevalence of this disease, right? Because it seems like it's something rare, but as the more that we are knowing about it, the more that people is recognizing it, and we are diagnosing it very, very rapidly. So they use a health system-based cohort that had clinical and genetic data. This is from Pennsylvania, and they had a lot of patients, like 163,000 patients. And among all of them, they look just randomly, see how many of these patients have variants in the UBA1 gene. And they found that about 14 of these patients have definitely pathogenic variants and some rare or likely somatic variants that are still not, the significance is not known. So then they look at the charts of these patients, and they found that all of these 14 patients actually had symptoms or clinical manifestations that are suggestive of VEXAS. So if we go by the prevalence of the variants, not necessarily the syndrome, it's actually pretty high compared to other diseases that we consider rare. So in individuals that are old or higher than 50 years old, for men, the prevalence is 1 in 5,000. For women, it's much rare, of course, 1 in 26,000. So overall, there's a prevalence in elderly population of 1 in 7,000. And in the entire cohort, regardless of age, the prevalence is 1 in 13,000. So just to give you a comparison, for example, for us, patients with hemophilia, we see 1 in 5,000 men. So it's very similar to VEXAS. And for rheumatology, so patients with SSTC, 1 in 10,000. So again, it's close. And then there are diseases that seem to be less prevalent, like MDS, 1 in 14,000, or GPA, 1 in 18. Again, so we might be seeing more and more patients with VEXAS. And just for everyone to understand what are the symptoms, we're just gonna go system by system so you guys are aware and you can recognize these patients whenever they show up to clinics or emergency rooms. So again, after fever, dermatologic manifestations are probably the second most common, and they can be the initial presentation in up to 63% of patients. And it's very variable. Here are some images, but if you look online, there's going to be hundreds of pictures with different type of rashes, but it's usually described as a sweat-like type of rash or urticaria-like nodules that are mainly involved in the trunk and the extremities. It's always erythematous, can be firm, tender, usually very tender, but non-pruritic. So that's very important. When patients receive treatment, the pain and the rash resolves very rapidly. Some patients have presented with papules, and something very characteristic is that when we use interleukin-1 antagonist treatment, because of all the inflammatory the underlying process that is going on, they develop localized reactions. So this is a patient that was receiving anakinra. In the areas of injection, he developed actually a new rash or worsening rash that he had before. And then some work that has been done from a pathologic standpoint. Some biopsies of these lesions have shown, again, neutrophilic dermatosis of 40% of the patients. And these myeloid cells that are infiltrating the skin are clonal, so they carry the somatic mutation. And there's also a lot of patients that have been diagnosed with leukocytoclastic vasculitis. For rheumatology, also the patients have a lot of arthralgias, chondritis. That, as I said, is one of the most characteristic symptoms. Like before in skin, we can see vasculitis. There was recently a case published where the patient presented with myositis-like picture, and then about 8% of the patients present with relapsing polychondritis. So this is from the rheumatology group at the NIH. They also have a big cohort of patients with relapsing polychondritis. So they were trying to see if they could find how to differentiate patients that have like standard RP versus patients that have RP related to VEXAS. And some of the differences that they found is that patients with VEXAS have other manifestations, like the ones that we have already talked about, like pulmonary infiltrates, for example, hematologic changes, while patients with RP usually just have like rheumatologic problems, and they have involvement of the trachea, for example, or large airways that we do not see in VEXAS. Another difference is that the chondritis that we see in VEXAS doesn't usually lead to long-term damage. So we don't see the type of like cauliflower ear that we see in RP. And the cutaneous involvement is also suggestive of VEXAS. So to try to predict which patients with RP might have VEXAS instead of just simple RP, they came up with an algorithm that if the patient is a male that has a high MCV, so has macrocytosis and a low platelet count, so some involvement of the hematologic system and not only RP, according to this study, of course, a small sample, this could predict VEXAS with 100% sensitivity and about 95% specificity. So in general, when you see patients with polychondritis, just think about other systems that might be involved, lung, skin, blood, and then that patient might have something else, and it could be VEXAS. As far as pulmonary manifestations, this was a recent review where they look at records of patients with VEXAS. It is retrospective analysis of all the cases that have been described or published so far, included close to 300 patients. And they found that 50% or half of the patients can have pulmonary manifestations. The majority have non-specific infiltrates. There's also quite a few of pulmonary or pleural effusions, and about 3% of patients have idiopathic interstitial pneumonia. And they also found some cases of pulmonary vasculitis, bronchiolitis obliterans, bronchiectasis, alveolar hemorrhage. So again, a variety of pulmonary symptoms similar to what we see in the skin and other organs. And then a little bit more detail in hematologic manifestations. So within the first 25 patients described at the NIH, they did a more extensive analysis in 16 patients of the hematologic changes. And 100% of them at the beginning had macrocytic anemia. Now we've seen that is a little bit less, maybe 90%, but still very, so it's a very significant sign that should raise suspicion. And up to 56% were transfusion dependent at the time of diagnosis. Then we also have thrombocytopenia, and we also have some other cytopenias, although less prevalent, like leukopenia and neutropenia, but it's mainly macrocytic anemia and thrombocytopenia. About 40% of the patients have been diagnosed with MDS, but mainly single lineage or multilineage dysplasia. These patients have been refractory to standard therapies for MDS. However, they have not shown progression to a higher risk MDS or acute myeloid leukemia. I think this is very controversial and it's very interesting. There was a lot of conversations about this during our meeting in ASH meeting in December, just last month, with the French group that they're also leaders in the VEXAS field right now. And a lot of these patients, they have been diagnosed with MDS because the bone marrow have shown dysplasia, but they don't really meet full criteria for MDS. They don't meet criteria for AML. And then a few cases that have been published where they have done serial bone marrows, for example, after giving treatment, some of these plastic changes have improved. So now this concomitant diagnosis of MDS in patients with VEXAS syndrome is under a lot of scrutiny, and maybe this will change, but again, this is what has been published so far. There's also a high prevalence of, I should have said here, plasma cell dyscrasia is not multiple myeloma, it's mainly monoclonal gammopathy of undetermined significance. And again, my personal opinion is this is just coincidental because we see a lot of MGOS in elderly population that are healthy. And in the bone marrow findings, we see vacuoles, dysplasia, that is what has led to the possible diagnosis of MDS, and the cellularity is usually normal or hypercellular. Another important aspect of the hematologic manifestations, as I said at the beginning, is the thrombotic events. So in this first series, up to 62% of patients, that's pretty high, had either a venous or arterial thrombotic events. And there's also a high percentage of clonal hematopoiesis. This is a completely separate topic, so I won't go into details, but again, it shows this interplay between mutations in somatic mutations or hematopoietic mutations that lead to some autoinflammatory conditions. So this is a description of a typical case that presents with macrocytic anemia, maybe some mild or initially platelet count that is normal, and then the anemia just gets worse to the point that the patient becomes transfusion dependent, and at that time we're also seeing another cytopenias, and eventually more dysplastic changes that can lead to the diagnosis of possible MDS. So to touch briefly on thrombotic manifestations, because this is what I focus on during my fellowship, and very exciting to be part of this group. So then after the first series was published at the NIH, we took more data on about 86 patients, and we saw that almost half of them have thrombotic events. So this is now considered a very prothrombotic condition. Of course, the pathophysiology of this is still being explored, but is even more prothrombotic than what we think about all the time when we're thinking about thrombophilias, right? Like factor V Leiden, prothrombin. So this is a real prothrombotic condition. Among these patients, 48% had venous thrombosis that usually manifests earlier in the disease, around 18 months after the symptoms onset, and 12% had arterial events that manifest later. And among the VTs, 30% had DVT, 14% had pulmonary embolism. There's a lot of superficial vein thrombosis that tends to be recurrent. So these patients present with like one thrombosis in the arm, then another one in the leg, affecting the superficial veins. And what is also very important for management is that half of these patients that have a VT event usually was unprovoked. So for whoever is familiar with the management of anticoagulation, when you have an unprovoked event, you always are wondering if you should keep these patients on anticoagulation forever. So this is an ongoing question in the VEXAS community. And some of these patients, about 17%, even had recurrent events when they were on anticoagulation. So we're also trying to figure out why is this happening and what is the ideal anticoagulant for them. And for arterial events, 8% of them have MI, and few had strokes, peripheral artery disease. So to try to understand why these patients are at increased risks of thrombosis, so we took a closer look at 30 patients, and half of these patients have a positive lupus anticoagulant. So about, let's say, 15 patients. And among these, 9 were retested, and the lupus anticoagulant was persistently positive in 8 of them. So if you are familiar with antiphospholipid syndrome, this is the criteria, right? You have a thrombotic event, and then you test for lupus anticoagulant, and it's persistently positive. But this story should remind you of what happened with COVID in the past few years. So these are patients that present with very significant inflammatory symptoms, and these lupus anticoagulants are probably non-specific. So this is, again, something that is being looked at more closely because your antibodies, so anticardiolipin, beta-2-glycoprotein, haven't been really positive. So this is probably just an incidental finding, but it's something that it's being looked at in both in VEXAS and in COVID. Also because a lot of patients, 43%, that didn't have a lupus anticoagulant also had thrombotic events. So probably it's not related to lupus anticoagulant, and definitely should not be considered antiphospholipid syndrome. What we have seen is that a lot of these patients with thrombosis have also high levels of von Willebrand factors and high levels of factor VIII. So again, this suggests that this is probably all driven by inflammation or endothelial activation that could be driving the thrombosis in these patients. And then in this same cohort, using logistic regression analysis, this has a lot of data, but what I was trying to show is that we couldn't really find a predictor for thrombosis in these patients. So no matter the type of mutation that they have, no matter the symptoms or the phenotype of VEXAS that they have, and even levels of von Willebrand factor or factor VIII, fibrinogen, and C-reactive protein, so or inflammatory markers, no matter if they were high, low, or what was going on, there wasn't any difference really between the patients that developed or did not develop thrombosis. So we haven't really been able to identify a potential factor that suggests a high risk for thrombosis. The only exception is cardiac involvement. So patients that have presented with myocarditis, pericarditis, or pericardial effusion, that is rare compared to the manifestations that we talk about, like pulmonary or dermatologic. It seems like these patients are at higher risk of thrombosis. And the other thing that we looked at, this was presented again in ASH in December, is that the presence of thrombosis did not impact survival on these patients. So what we've seen so far is that the patients with VEXAS usually die either of progression of disease, progression of cytopenias, with infection is probably the most likely cause. So these studies are being done to try to understand the mechanism of thrombosis in these patients. The thought is that this is related to immunothrombosis, most likely. And what I was saying, the main question is, what should we do with anticoagulation? So if we have a patient with VEXAS, should we just start prophylactic therapy because of the high risk, about 50% risk of having a thrombosis, or should we just wait for an event and then start treatment? And if there's an event, should we treat indefinitely? So these are ongoing questions, the duration of anticoagulation that we are still trying to figure out. And obviously, it's probably going to just take more time and longer follow-up of these patients. So we've only been talking about men because it's an X-linked disease, but there have been cases described in women. So basically the mechanism is very interesting. So there were 2 cases of women that developed an acquired X monosomy. So they lost one X chromosome and the other one unfortunately had the mutation. So they developed VEXAS syndrome. And there was one case described in a Turner syndrome patient. So she didn't develop the monosomy, but she had an X monosomy, and then the chromosome that is left has the mutation and then develop the manifestations. There's another case that she had normal karyotype analysis. So by still an unknown mechanism, this was another female patient that developed VEXAS. But again, it's less than 0.0% of the patients that are women. The majority are men. And as I said at the beginning, the mortality is very important to consider. In the first case series, the 25 initial patients, around 40% of them had died. Some of these diagnoses were made retrospectively. And then another French series showed a 5-year overall survival of around 60%. So mortality is pretty high. It's probably depending on many factors, not only VEXAS, but as I said at the beginning, these are elderly patients in their 60s, 70s, usually have comorbidities that could be playing a role in the high mortality. And the French group, they have published the largest case series so far, 116 patients, 116. And they saw that depending on the mutation, so if they had the leucine mutation, probably the survival was better. Maybe these patients have a less severe course, while the other 2 mutations lead to an increased risk of mortality. So to conclude with the second objective, recognizing and diagnosing patients with VEXAS syndrome for every healthcare provider. So suspect always in male patients, don't forget female, but very rare. So suspect in male who present in late adulthood with any type of systemic inflammatory symptoms that do not fit a specific diagnosis. They usually have skin involvement, lung involvement, and hematologic abnormalities. Remember, macrocytic anemia is very important. And another clinical suspicion is that all these symptoms respond very well to steroids. And we'll talk a little bit more about this in treatment. So for the next objective, how to treat patients with VEXAS syndrome. So there's been different proposals, but unfortunately, no treatment has been really successful with the exception of steroids. The patients respond very well, but unfortunately, a lot of them then are dependent on steroids, and we all know about the side effects. So we definitely have an urgent need for a steroid sparing agent that works as good. So the proposals are to target the clone in the bone marrow, obviously, where the mutation is coming from. So for these, allogenic stem cell transplant is an option. Hypomethylating agents that have been successful in treatment of MDS have been tried, and some other synthetic lethal drugs. Another option would be to block the inflammatory pathways, what we do with steroids, but doing it with other drugs that have less side effects. So targeting interleukin-1, 6, TNF, interleukin-1 beta has also been done in some K reports. Using JAK inhibitors, cyclosporine to attack T cells. So many different targets in the immune system have been tried. Not all of them have been successful. And then, of course, as I said, these patients are usually very sick, so they're going to need a lot of supportive care. So they're going to need transfusions. If it's only anemia, for example, erythropoietin has been used. Thromboprophylaxis, as I said, is controversial, and we might consider also infection prophylaxis because some of the patients have presented with leukopenia and neutropenia. So regarding transplant, it's very challenging, again, because of the age of the patients, the comorbidities, and the thought that the risk of complications after transplant, including transplant-related mortality, GVHD, is probably very high in these patients. So patient selection is very important. The last time I talked to the group at the NIH, they haven't been able to enroll any of the patients in their protocol to transplant patients with VEXAS, just because they don't meet the criteria, right? When they look at heart function or liver function or all of the criteria that they have, the patients are just either too sick or have comorbidities that don't allow them to go into transplant. The other thought is that we need to think about an optimal condition regimen. probably a reducing density condition regimen is enough, because it's not like we're treating a malignancy where we need myeloablative regimens that are just more harmful or have more side effects. And then the timing of transplant is also very important, perhaps treating the patients with other treatment options, and then when they're responding, when they're at a better time in the disease with less symptoms, maybe that's the time to do the transplant. But of course, this is all very hard to coordinate. However, there's been some reports in a French series of 6 patients that were transplanted. 1 died, 2 had a clinical response, but this with a very short follow-up, only 3 and 5 months. So we'll have to see what happens with these patients. And then half of their patients, so 3 actually had a good clinical response after a long follow-up, 32, 38, and 37 months. So it is potentially curative. It's just very hard to do in practice. And there was another UK series where they transplanted 4 patients and only 1 survived. So very, very challenging, definitely. Regarding other anti-inflammatory therapies, there has been 1 case report where no treatment was used, only erythropoietin for management of the anemia. So as when I showed the Kaplan-Meier curve of mortality, some patients may be present with a more indolent course, but this is not the majority. The majority of patients have received 3 to 4 treatments from the ones that I listed in the like steroids or interleukin-1, interleukin-6, and then they just have to be switching from one to another because there are no adequate responses. And about half of the patients become dependent on steroids at high doses, 20 to 30 milligrams per day. So again, this is where all the problems also come from the side effects of steroids. This was a study from the French group. They used the time to needing a next treatment as a surrogate to try to determine which treatments were more successful. And you can see, for example, methotrexate at a median of 6 to 7 months, patients already are not responding. And very similar to the anti-inflammatory medications, anti-TNF and anti-interleukin-6, about a median of 3 to 5 months, the patients are no longer responding. Cyclosporine surprisingly showed a little better response in this study. So the median time to need a new treatment was about 13 to 14 months. JAK inhibitors didn't reach the median, but this was obviously a very short follow-up, and I'll talk a little bit more about this. And then azacitidine has also been promising, although a very wide range of patients. Some needed another treatment around 8 months, but some of them reached close to 40 months without needing a treatment. This is a very busy slide, but my point here is to show you that all these therapies that target the inflammatory pathways in general have not been successful. So here, in all the experience, you see partial to good response, sustained response, and partial response, but then the majority said that effect was transient, failure to do a sparing of steroids, failure to prevent recurrence, subsequent development of more symptoms, no efficacy, failure to prevent recurrences, disease recurrence, persistence of some symptoms, failure, transient, recurred. So again, the patients go through all the treatments available for rheumatologic conditions, but in general, it doesn't seem like this is the answer. So azacitidine, as I said, because of the experience with this drug in MDS, it has been tried. About half of the patients in this cohort of 11 showed improvement in the inflammatory symptoms and in the steroid requirements, which is really good. And two of these patients also showed response in the hematological parameters, like the anemia and the thrombocytopenia. And this was a long follow-up, which is important for this type of hypomethylating agents that sometimes we need to wait for months to see the response. And then the most promising therapy so far is JAK inhibitors. So this was a retrospective analysis from France. Again, 30 patients were treated with different type of JAK inhibitors. The majority received ruxolitinib. And they found, they defined clinical responses and biological responses with a reduction on C-reactive protein levels. So at a month, around half of the patients had achieved the responses, both clinical and biological. And at 3 months, again, it was maintained. Around half of the patients reached both responses. And the median duration of response wasn't reached at 6-month follow-up. And it seems on doing subgroup analysis, although considering this is a small patient sample, it seems like ruxolitinib might be a little bit better. So at 3 and 6 months, there was a significant better response in patients that were receiving ruxolitinib of 80%. And at 6 months, they were also able to reduce the doses of steroids. So again, I'm not showing clinical trials and I'm not showing a very high quality evidence, but this is what we have because of how rare the disease is. And it seems like JAK inhibitors might be the most promising agent. So for this last objective, to understand how to treat VEXAS syndrome, remember that steroids work, but they're not ideal. Transplant is potentially curative, but in real practice is very challenging to achieve in these patients, and clinical trials are urgently needed to try to figure out the ideal therapy for the patients. So to conclude, I hope you have understood that VEXAS syndrome is another fascinating example of the relationship between somatic mutations and inflammatory diseases. And there's a term now in the literature that's called hemato-inflammatory diseases, and you're going to be hearing more about that. Clinical trials are urgently needed for patients with VEXAS syndrome as well as other rare diseases. Multidisciplinary approach is necessary because of how different the patients presents, and probably everyone in the community is going to be seeing some of these patients. So mainly for diagnosis and then to refer to the specialties for treatment. And international collaboration can definitely make a difference in patients with rare disease. I think VEXAS is a perfect example. The people at the NIH continue working very closely with the French that are leading the field, and hopefully this will lead to answers for these patients.